Hello everyone, welcome to my channel Prosto Hub and myself Dr. Jolsna. So this is the second session of our current topic implant failures and its management. Previous session we have discussed the introduction, definitions, Albertson criteria for implant success, classification of implant failures, the different signs and symptoms, ailing, failing and failed implant, the different factors contributing to implant failure, the perioperative errors contributing to implant failure, and the parameters used to evaluate failing and failed implants. And in this session, we'll be discussing peri-implantitis in detail. So this is an important topic that you can expect as a short question from the implantology section. And let us see the contents. The peri-implantitis will be discussing the definition, the different classifications, etiology and pathogenesis of peri-implantitis, the risk factors, clinical features and treatment. So before getting into detail, I request everyone to please do like and share my videos if you are finding these videos useful. And if you have any queries, any topic that needs to be discussed, any suggestions or feedbacks, please do comment below the video or you can mail me at this mail ID. So let's start. So what is peri-implant diseases? So these are inflammatory conditions affecting the soft and hard gum tissues around the dental implants. And these peri-implant diseases are generally classified into two categories. One is the peri-implant mucositis and peri-implantitis. So American Academy of Periodontology defines peri-implantitis as an inflammatory lesion of the mucosa surrounding an endosseous implant and with progressive loss of supporting peri-implant bone, whereas peri-implant mucositis is a disease that includes inflammation of the soft tissue surrounding dental implant without additional bone loss after the initial bone remodeling that occurs during healing following the surgical placement of the implant. So, in peri-implant mucositis, the inflammation is found only around the soft tissue of dental implant with no signs of bone loss. And this is a precursor to peri-implantitis, and this may be successfully treated and it is reversible if caught early. Whereas in peri-implantitis, the inflammation is found around the soft tissue with deterioration in the bone supporting the dental implant. And peri-implantitis usually requires surgical treatment. So let's see the classification of peri-implantitis. So the newer proposed classification of peri-implant defects in article discusses many classification system of the peri-implantitis, and here I shall be discussing two among them. So the first one is the Fromm and Rosen classification. So in the year 2012, they classified peri-implantitis based on the stage of the disease. So it was classified as early, moderate and severe. So let us see the features of these classes. Early class, that is the PD, that is the probing depth, is greater than or equal to 4 millimeter along with bleeding or suppuration on probing, and the bone loss is less than 25% of the implant length. Whereas in moderate, the PD probing depth is greater than or equal to 6 millimeter and bone loss 25 to 50% of the implant length. And in advanced case, the PD is greater than or equal to 8 mm and bone loss greater than 50% of the implant length. Another system of classification exists which is based on the amount of bone loss along with shape of the defect. So this classifies peri-implantitis into four classes. In class 1, there is slight horizontal bone loss with minimum peri-implant defects. 2, there is moderate horizontal bone loss with isolated vertical defects. Class 3, moderate to advanced horizontal bone loss with broad circular bony defects. Class 4, advanced horizontal bone loss with broad circumferential vertical defects as well as loss of oral or vestibular bony wall. So this is the different four classes of peri-implantitis based on the type of bone loss and along with the defects that is associated with it. To the etiology of peri-implantitis. So two primary etiologic factors are said to be causing the peri-implant marginal bone loss, and they are bacterial infection and biomechanical overload. And in addition to these factors, there are other etiologic and modifying cofactors also which have been considered as potential initiator of peri-implant diseases, and they are traumatic surgical technique, smoking, inadequate amount of host bone, which can result in exposed implant surface at the time of placement and also a compromised host response. First one, the bacterial infections. So most authors compare the peri-implant diseases to periodontal diseases because they are primarily plaque induced. So if plaque accumulation happens on the implant surface, the subepithelial connective tissue becomes infiltrated by large number of inflammatory cells and the epithelium appears ulcerated and loosely adherent as seen in the picture. So when the plaque front continues to migrate apically, the clinical and radiographic signs of tissue destruction are seen around the implants. And in addition, the implant lesions also extend into the supracrustal connective tissue and approximate the bone marrow, while the lesions associated with teeth do not happen in such a way. The next one is biomechanical overload. So about the occlusal overloading on implants, we have discussed in implant occlusion. So this biomechanical overload results in microfractures at the coronal aspect of the implant bone interface, and thereby there is loss of osseointegration in this region, which results in apical downgrowth of epithelium and connective tissue. So the role of overloading is likely to increase in four clinical situations. The first one, the implant is placed in poor quality bone when the implant position or the total amount of implant placed does not favor ideal load transmission over the implant surface. So there is a patient is having the third factor is the patient is having a pattern of heavy occlusal function that is associated with parafunction, and finally the prosthetic superstructure does not fit the implants precisely. So this is another important causative factor, that is biomechanical overloading for the initiation of peri-implantitis. Let us see the pathogenesis of peri-implantitis. So the pathogenesis is quite similar to periodontitis and natural teeth. So after an implant is placed in the oral cavity, the exposed titanium surface, they accumulate glycoproteins from the saliva and thus they form salivary pellicle. And this pellicle attracts bacteria from the oral cavity and thus they form biofilm. So the first formed is a salivary pellicle from the glycoproteins, and these pellicles attract bacteria from oral cavity to form a biofilm. Now, the formation of biofilm occurs in 5 stages. They are the initial attachment, irreversible attachment, the maturation 1 and 2 phase, and finally dispersion. So, as you can see in the picture, the first one is the initial attachment where the mobile cells attach to a rough surface, that is a titanium surface. So the mobile cells attach to the implant surface, and then the irreversible attachment where the attached cell secrete an extracellular matrix and lose their flagella. So this is the irreversible attachment stage. Then comes the maturation 1 where some of the superficial cells, they secrete matrix dissolving enzymes and they begin to develop flagella. And in maturation 2 stage, the outermost layer of the bacteria begins developing spores within their cytoplasm. So in maturation 2, there is formation of spores. And finally, the dispersion stage, where the outer bacteria detach from the colony and move with their flagella, or they liberate the spores, and these bacteria move to newer areas to develop newer colonies. So these are the 5 stages: the initial attachment, irreversible attachment where they secrete extracellular matrix, maturation 1 stage where they secrete the matrix dissolving enzymes and begins to develop flagella, the maturation 2 stage where they develop spores, and finally the dispersion stage. The biofilm is formed, and this biofilm triggers an inflammatory response which makes the blood vessels large and more permeable. And this will facilitate migration of neutrophils, that's the PMNs, into the pocket space around the implant. And as the inflammation progresses, the collagen around the blood vessels is also lost and lymphocytes accumulate in this area. Now, the underlying connective tissue also exhibit increased lymphocytic infiltrate and thereby increasing the pocket formation. This is characterized by the porthole-like defect that is seen in the radiograph. So this is the porthole-like defect. And This creates an environment that favors more microbial proliferation. Now, the disease progression in the implants is different from natural teeth in a way uh, that it is fast and direct progression of infection in case of implants, because in natural teeth the direct progression is prevented by the presence of cymendum and Sharpie's fibers. So here these structures are absent and there is direct progression of infection. And also the inflammatory cells, they release cytokines which has got osteoclastic activity and thereby resulting in bone destruction. Next, coming to the risk factors for peri-implantitis. So the first one is previous periodontal disease. So studies shows that the patients with a history of aggressive periodontitis are susceptible to peri-implantitis. So there is a positive correlation between the previous periodontal disease and peri-implantitis. The next risk factor is poor plaque control. So we have already said that many authors assume the peri-implantitis as plaque induced, and this is the most important risk factor in peri-implantitis. So, in order to avoid the plaque accumulation, the prosthesis should be designed in a way to facilitate easier cleaning. So, studies shows that implants with screw retained prosthesis show decreased peri-implant changes when compared to cement retained prosthesis, and this may be due to easy retrievability of the screw retained prosthesis and also subsequent maintenance in the region. The next risk factor is residual cement. So incomplete removal of cement is a major concern, and we should be careful to remove the cement properly after cementation. So this is extremely important as excess cement in the peri-implant sulcular area will not be detected in routine radiographs, and they may irritate the surrounding soft tissue, contributing to poor plaque control, and they also create a rough surface and promote bacterial plaque formation. So this leads to peri-implantitis. The next factor is smoking. So we know that the incidence of peri-implantitis increases in smokers. And the next one is genetic factors. So studies shows that there is a positive correlation between peri-implantitis and genetic variations. The next one is diabetes mellitus. So high blood glucose level affects the tissue repair and host defense mechanism, and they also impairs the reparative ability of the tissues. So this can lead to peri-implantitis. Next one, occlusal overloading. So we have already discussed about the biomechanical overload, which results in bone loss at the implant marginal bone interface. So the implants, they generally do not tolerate the off axial loads because they lack periodontal ligament. So occlusal overload along with a poor oral hygiene can result in massive bone loss and peri-implantitis. And finally, the micro gap and biofilm growth. So what is a micro gap? It is a space between the implant components. So this gap is the size of the gap that is between the implant and the abutment. Ideally it should range from 1 micron to 10 microns, but when dental restorations are fabricated, these micro gaps tends to increase 50 to 150 microns. So there is inflammatory cell infiltration in the peri-implant mucosa at the borderline between the abutment and implant, and this can lead to peri-implantitis. So these are the important risk factors that leads to peri-implantitis. Coming to the clinical features of peri-implantitis, so they are suppuration, instant bleeding on probing, progression of the pocket depth, radiographically detectable bone loss, inflammatory reaction of mucosa, and mobility. And also the implant quality scale, which we will be discussing in the coming slides, can be used to clinically evaluate peri-implantitis. Now let us see the treatment modalities for peri-implantitis. So the therapy can be broadly classified into two types, that is non-surgical and surgical. Non-surgical comprises of local debridement, air abrasion, detoxification, laser therapy, photodynamic therapy and drug therapy. And the surgical technique include the surgical correction and implantoplasty. So let us see one by one in detail. First one, local debridement. So the implants should be cleaned with instruments which should be softer than titanium surface like rubber cups, floss, interdental brushes, plastic tips, etc. And ultrasound scalers cannot be used because they roughen the implant surface and also debride the surface of the implant. So instead of this ultrasonic scalars, a recent advancement is the vector system, which consists of a modified ultrasound scalar with a linear deflective property. That means that the tip, it moves axially and parallel to the surface of the root. So the vector system claims a thorough removal of the biofilm and bacteria and ensures smooth and clean surface. This is air abrasion technique where abrasives like lysine, titanium dioxide, hydroxyapatite, tricalcium phosphate, etc. are used to clean and detoxify the implant surface. So, studies shows that cell attachment and re-osseointegration improves by around 40% after this air abrasion technique. Is detoxification or decontamination by various chemicals. The tetracycline, which is bacteriostatic, the broad spectrum antibiotic, then 24% ethylene diamine tetracetic acid, and that is used to remove the biofilm. Then chlorhexidine gluconate and hydrogen peroxide, that is cotton pellets soaked in these chemicals, which can reduce the number of the bacterial counts. The citric acid, again, it reduces the microbial count. So these chemicals are used to detoxify or decontaminate the implant surface. So in the figure is the mechanical debridement, which is followed by the surface treatment with 24% ethylene diamine tetraacetic acid gel to provide the chemical surface decontamination. Is the laser therapy. So lasers are primarily used to decontaminate the surface of the implant as well as the soft tissue surrounding the implant. So some of the lasers that are utilized are carbon dioxide laser, diode laser, erbium YAG, erbium chromium YSGG, etc. And lasers have also got special uses in the implantology field. So they are used for granulation tissue removal, the defect detoxification, which we discussed, hemostasis, biostimulation, enhanced healing and stimulated bone regeneration. And surface decontamination, it maintains the surface microstructure and enhances bone to implant reosseo integration. Next is a relatively new treatment modality that is called as photodynamic therapy, which uses a combination of diode laser with the toluidine blue photosensitizer, and when combined, this has got bactericidal effects against aerobic and anaerobic bacteria by the release of reactive oxygen species. So when this high energy single frequency light is combined with photosensitizer like toluidine blue, they releases the photosensitizer get excited and causes release of the reactive oxygen species, which results in destruction of bacteria, and thus it enhances bone formation and healing. So this is photodynamic therapy. Final one under the non-surgical technique is the drug therapy, where drugs like tetracycline, doxycycline, amoxicillin, metronidazole, ciprofloxacin, etc. are used in conjunction with manual debridement. Also, localized drug delivery systems are used along with manual therapy, like the Acticide that is seen in the picture, which is a tetracycline strip to treat Peri implantitis. Is the surgical correction, which comprises of two types of surgery, the resective surgery and regenerative surgery. So in resective surgery, it involves the removal of the peri-implant osseous defect using ostectomy, osteoplasty, and also bacterial decontamination. So let us see the indications of resective surgery. So resective surgery is usually done in implants in the non-aesthetic areas, and when there is peri-implant pocket depth more than 5 millimeter, we opt resective surgery, and when there is presence of extensive bone loss and also soft tissue separation. And the contraindication or the major disadvantage of resective surgery is that there is severe post-op recession, and so it is generally avoided in the aesthetically demanding areas. Coming to the regenerative surgery, which includes thorough debridement followed by bone grafting. So in this technique, a flap is elevated and the diseased portion of the bone and the soft tissue is thoroughly cleaned by using specially designed curettes, scalers, chemicals, etc. as mentioned in the above slides, and then this is followed by grafting with particulate bone and follow-up. So studies have shown that when this is done properly, it results in bone regeneration and re-osseointegration. So as you can see in this picture, there is the labial soft tissue recession around the dental implant in the aesthetic zone, and this flap is elevated, and then by using guided bone regeneration with mineralized allograft, the regenerative therapy is done. Coming to the last resort after all conservative treatments have failed, and that's implantoplasty. This technique involves removal of the affected surface of the implant using rotary instruments. So the goals of implantoplasty is to decontaminate the infected implant surface and to gain a smooth surface which decreases plaque adherence and also the decrease the formation of biofilm on the surface. So implantoplasty, this is usually performed together with resective osseous surgery and an apically positioned flap. And this procedure can be performed using a high-speed diamond burr to remove the implant threads, followed by an Arkansas burr to polish the surface in order to prevent the formation of plaque and biofilm. So let us see the disadvantages of this technique. There is excessive production of heat while working with these diamond burrs, and there is chance that there is deposition of implant material in the surgical field, and there is damage to the implant surface and also weakening of the implant structure. An article on peri-implantitis by Rokhaya et al. Has classified the treatment of peri-implantitis diseases into three groups. The first one is a non-surgical, which consists of mechanical methods and usage of antiseptics and antibiotics. Then surface decontamination, that includes decontamination using chemicals as well as lasers. And finally, surgical treatment, which includes air power abrasive, resective surgery, and regenerative surgery. Thus, we have come to the end of this session, peri-implantitis, where we discussed the definition, classification, the etiology, pathogenesis, the different risk factors, the various clinical features, and in detail about the various treatment modalities. And the next topic to discuss is the maintenance of implant, which we will be discussing in our next session. So thank you all for watching my video. Please do like, share and subscribe to my channel if you are finding these videos useful. And if you have any queries, any topic suggestions or any feedbacks, do comment below this video or you can mail me at this mail ID. So it's a bye from Prosper Hub until our next session.